And I'll just take a moment and introduce our speaker for today, who is Dr. Cheryl Forchuk. Dr. Forchuk is a distinguished university professor at the Arthur Labatt Family School of Nursing at Western University, and she has a cross appointment in the Department of Psychiatry, Schulich School of Medicine and Dentistry, also at Western University. She's a scientist with Lawson Research Institute and has received many accolades, including the Officer of the Order of Canada just recently, which is incredible. Congratulations again. Um, and the Order of Ontario, as well as many acknowledgements for her excellent contributions to mental health practice and research. Dr. Forchuk's work spans more than 3 decades, consistently using participatory action research approaches, including people with lived experience of mental illness and as co-investigators. Her research focus is consistently her research focus consistently includes frontline service providers and policy decision makers, which has been fundamental in addressing highly relevant issues and identifying solutions that are implemented into practice. And so many of you, I see who's on the list here, many of you know Cheryl and know the wonderful work that she has done over a long period of time. And it's an honor to welcome you today. So I will put myself on mute and I'll hand the floor over to you, Cheryl.
Well, thank you so much, Carrie, and thank you for the kind invitation. I didn't put a slide in for a land acknowledgement. I wasn't, I should have asked to see who would do that, but I think it's particularly important when with our land acknowledgements to really assess and reflect on the specific topics. And so I would say in terms of homelessness, we do know that our Indigenous people are consistently overrepresented in this population and people struggling with this issue. And as perhaps we can reflect on that during this presentation and think as well how Indigenous peoples of all groups, First Nations, Métis, and Inuit, would experience homelessness and some of the issues that we're talking about. So thank you again for the kind start. Oh, I've got it. Okay. So just a few objectives. I'm hoping one of the big challenges with homelessness, where people talk about it as being one of those wicked problems, is the idea that there's so many different systems involved. And so one of the things I'm hoping to talk about here is to understand how these systems interact. But more important is that understanding the systems help us understand strategies that need to be in place. And to get there, that involves advocacies. And it certainly fits in with the overall purpose of this series in terms of these health inequities that we'll also be focusing on. So, oops. Now, I know this is kind of, it's sometimes if I'm talking to a group, I actually ask this as a question and have a few people respond to it. But I think I kind of, given who's showing up today, I think we would agree that people would think that housing is a right. The thing that a lot of people are not aware of, and we may have some students that would be less aware, that there's actually a UN proclamation on establishing that housing is actually a human right. And Canada actually did sign on to that UN proclamation. So think about that as we talk about these issues. To what extent do we actually honor that right? And we do know that we have actually been investigated in Canada related to our poor housing policy. And a lot of what I'm going to be talking about today is actually policy. Sometimes I also will ask the group to what extent they've been to shelters. This is an example, and this is actually a few years old now, but a very well run shelter. But take a look at what that means in terms of issues such as privacy, safety of belongings. We actually in London are very fortunate. A lot of our shelter space, actually, we have a lot of private rooms and double rooms, much more so than many other communities. So this is really kind of an overflow area. It's kind of one of the kind of worst case scenarios that we would actually find in some ways in our shelters in London. But I'm always reminded as well of uh, some of the work that has been again done by uh, the term just others that actually found that many shelters do not meet the requirements of a UN refugee camp. Not in London. I'm not saying that would be the case. We do, but in other communities, such as Kathy Crow's work, where they took measurements in the law of the Toronto ones, this is a few years ago, and found that the distance between beds, the number of bathrooms per person, et cetera, did not meet the UN refugee camps. And so then, to what extent do we actually enact this idea of a right? And again, we also need to understand that some people prefer nothing to shelters. This impacts my work in a lot of different ways because I focus on interventions, and because we have a bias in how we count homelessness that focuses on who does go to shelter or who goes to the homeless serving sector, but we often end up missing the people who've made the decision not to go that route. Um, and then it makes it hard to know whether you had an improvement if you don't have an accurate baseline. Um, my background, my PhD is in psychiatric mental health nursing. That's my area of clinical area. I worked in that area for many years before going into academia, and these are some of the issues that drew me into the homeless population. And I should say too, I often throw this for the young people. When I worked at a psychiatric hospital for a number of years, if we discharged someone into homelessness, we had to fill out the same patient incident report as a patient assault. And I remember the time it happened twice in 1 year, and we had a huge meeting of all the managements. How could we fail people twice? And I use this as an example to show we did not always have this problem. And when I go through some of the slides and some of the policy issues, I'm hoping that you can see that things had changed. And flash forward a few years after, when I was implementing a discharge model in 6 communities across Ontario. And I was finding so they were being discharged from psychiatric facilities, and I was finding across all 6 sites across the province, people who had been discharged were homeless. I was finding some of them in shelters. Not me, just me personally. My team obviously was 6 sites. I had a team working on that. And when I would talk to the clinical staff and say, what's going on here? Why am I finding people in shelters? People tended to focus on the individual level. They don't have the proper housing skills, or they don't have the proper housing history. And I would say, well, how is it across the province everybody simultaneously lost housing skills? That makes no sense. And when we go into this model and look at some of those policy changes, it makes more sense as to what happened. How did we go from, like I say, in my clinical experience, having tuned an entire hospital in a year to something that was happening on a fairly frequent basis? But again, think about these questions. Is it something about mental illness, something about homelessness, something about societal response? I don't know if there's a couple people that wanted to respond to this slide before we move on. Has anyone got their hand up? Carrie, I'll have you find out if they do. Otherwise, I'll keep moving.
Yeah, if you wanted to comment, please put your hand up, or you can also add a comment to the chat, and I can kind of call on you.
Anything? Okay. I will say that I land hardest on the societal response, but there are some issues about these other ones as well. Um, in terms of the thing about illness that predisposes to homelessness relates to stigma, where in and we know that people with mental illness, including addiction, are the most stigmatized group in society, and that's not just Canada, that's worldwide, and that also includes things such as landlords. It includes things like employment that certainly predispose people to homelessness because of the lack of income. We know that when you've been diagnosed with a mental illness, no matter the socioeconomic, that can happen to anyone at any socioeconomic status, but the literature talks about so-called drift into poverty, because, and a lot of that relates to stigma. Is there something about homelessness that predisposes to mental illness? I remember the City of London a number of years ago was looking at youth arriving in London from the surrounding rural areas. And they were rather shocked to find that even when they looked at youth with no prior substance use, that means no marijuana, no alcohol, no nothing, but arrived, it was 6 weeks to IV drug use. Sometimes people consider that to be a unidirectional, that people are homeless because they use substances, and they don't look at the fact that that can happen for sure, but it also can very much happen the other way around, that people use substances to cope with a situation, and depending on time, we can come back to that. And the extent to which we value people with mental suffering with mental illnesses, we value um, people who are unhoused, sometimes the societal response is certainly inadequate. So, although it's a wicked problem, although it's complex, sometimes people use that as an excuse for inaction, that it's too difficult. And this is why I like this analogy of musical chairs, because it shows how how it, although wicked, it is understandable. If you can understand musical chairs, you can understand homelessness. And I'll say we ended up coming up with this model actually when I was at Roth Home one time, and I was seeing what we when we would have focus groups there, we'd also have childcare groups, and one of the for different age groups so that the parents could attend the focus group. And one time, the students I had played musical chairs with the people, with the kids, and notice how disturbed they were when they lost the chair, which really had us thinking about this analogy. And then when we went to the literature, we actually found about 6 different articles that never even referenced each other, also had this analogy, although we developed it, I think, a little bit further. But I think it's just that it's so intuitive that people independently, in many cases, realize that this is actually a good way to understand. So you all understand musical chairs, I think, about people circling the chairs. There's music, the music stops, people grab a chair, the chairs keep disappearing, so people keep going out of the game. Um, and so I want you to think of that analogy and consider that the chairs in the game represent the amount of affordable housing within the community. Now, there's many definitions of affordable. CMHC, as you know, would be talking about like at the easiest level or whatever, like that you shouldn't be spending more than 30% of your income on housing without being considered in this need. And then we got different definitions with the higher level, 50, et cetera. But the problem with those kinds of definitions is it's blind to total income. And I would say if you make 100,000 a year and are spending 30,000 on housing, that's not the same thing as making 10,000 a year and spending 3,000 on housing in terms of what do you have left for anything else in your life. So when I'm talking about affordable housing, I'm talking about people who are in poverty, people at the lower socioeconomic bracket? What about someone on Ontario Works? What about someone on ODSP? What about someone on who's relying on OAS? Um, what housing at that income level is actually available? And I think that gives us a better guide than just using a 30% that's actually blind to income. Because we can see fairly expensive homes built using that criteria that someone in those categories could never possibly afford. So that's what the chairs represent, the housing that that group could access. The people circling are the people at those income levels. So very clearly, if there's more people that need housing at that level than there is housing, you're going to have a homeless problem. It's not rocket science. The other thing with the game to consider uh, is the music. You're at risk of losing your housing when the music stops. So, what is the music? And this is the part when other people talk about musical chairs as an analogy. I find they mostly focus on the chairs and the people. But the music is also important because it represents change. When you think of music, it's about transitions at its most basic. So, what are the transitions where someone might lose their chair? Um, any suggestions from the audience about transitions? Moving and losing rent control. Absolutely. Excellent one. Illness, yes. And in fact, particularly any kind of chronic illness. And this is again where I have focused on people leaving hospital as a feeder. Change in family size, yes, for sure. Great ideas. Any other ones? How about leaving children's aid? I mentioned leaving hospital, leaving jail, relationship breakups. Yeah, employers move, shut down. Yeah, losing employment, lots of job. Yeah. Um, uh, Eviction, rent eviction. We saw tons of rent eviction during the. So there's many times that the music stops. Now, so we do. So when you're looking at prevention work, looking at the transitions is really helpful. So, and again, that's why we've done a lot of projects to prevent discharge to homelessness, because it's a transition point. What we found, it was often a point where people started their journey of homelessness, but could also be a time to take them out. But despite the music, if you don't deal with the chairs and the people circling, it still won't change the rate of homelessness. It may change who becomes homeless by dealing with the transitions. And it's much easier to prevent a problem, like to prevent that first episode of homeless rather than deal with someone who's been homeless for 10 years. It takes a lot, it's a lot more difficult and a lot more suffering involved. But we don't totally move the dial if we don't deal with the people circling and the chairs. So I'm just going to go a little bit more there. So what's happened to chairs? And so back when I was starting seeing that problem, when I had that other study, that was in the early 90s. Uh, so what we were finding at that time, housing development, social housing, etc., was CMHC had a much stronger role in social housing at that point, and it was downloaded from the federal level. Where it was pre-1990s to the provinces. Uh, and in Ontario, we hit a point in 1995. So, and I got to say, when it was downloaded, the provinces did not want it. Contracts for public housing were canceled hugely during that period. They were hoping by canceling these things, by not really picking it up, that somehow this would get reversed. Um, so the it, which didn't happen. In Ontario, during the Harris years, I always semi-joke and say, well, they looked at that saying, well, that's a horrible idea, what it did to the province and social housing. How can we make it worse? And in Ontario, what they did was download it to the municipal level. Okay, I'm trying to click on this thing. Hold on. Okay, there we go. And keep in mind that Canada is the only industrialized nation in the world that does not have it at the national level. So, as bad as it is to move to the provincial, imagine Ontario having it at the municipal level. So what we've and when you have this kind of bad policy, it's not like the next morning you wake up and there's a lack of social housing. It's about the lack of new building that take years, right? As well as losing old housing. So it takes a while for that to be created. And for example, across the country in 1980, prior to this, we had a good year where we had 25,000 units of social housing created versus in that period right after we had sometimes less than 1,000 units, and that means like individual apartments. That's not apartment buildings, that's units within apartment buildings, so or whatever, in the entire country. So we were trashing, so we had a huge loss. And Canada was never at the level of social housing that we see in many European countries to start with. So then we've more recently seen just general rising for housing, including rentals. And in more recent years, we've certainly seen a renewed interest in housing development. But again, is that affordable housing? To what extent is it the chairs that I'm talking about? And I think you would agree, what we've seen because of this bad policy changes is some chairs in pretty bad shape. So then who are the people circling? And we talked about the poverty level. Now, ideally, people have employment. But again, there's many issues we've seen recently around employment. Um, and if you rely on income supports, if employment is not possible, not only not possible because of your physical or mental condition, but sometimes because of the willingness or job skills. It can also be, again, going to that stigma issues that we talked about. And this is where things, particularly like your basic income support and your disability support, are really important to consider. Some of the reasons we'd be less likely to focus on these bottom ones is because they rely on already having employment, but we can't totally leave them off the list either. Okay, I'm trying to click forward. Okay, the big question with this is that actually a livable amount of money? And I know the fast answer is no. I did not update this. This is about a year and a half out of date. Um, but you all realize, I'm sure, that when someone is on Ontario Works or ODSP, there's a housing or a shelter allowance as well as your basic needs. So like there's two parts to it. So this is not showing the total income. This is just looking at the shelter allowance. But the thing is, if the shelter allowance doesn't cover your total cost, you go into the other amount. So even if this was 18 months ago, to what extent could you find accommodation? And keep in mind, this is supposed to include utilities for $390. Like that is obscene to even suggest it, or that a couple for $642. Some of the reason I include the higher numbers, I get very tired sometimes of hearing how people on OW get extra kids to up their money. Yeah, I've got 4 kids and a couple. I don't think you're getting rich on an 844 housing allowance. So we basically saw a game of musical chairs turning ugly. And again, in Ontario, keep in mind that in those same Harris years, the basic income support, which became Ontario Works, was actually cut by 25%. And then we went through over a decade of no increase and then small incremental since then. So those income supports are really important. And I will say many groups, such as the Registered Nurses Association of Ontario, have argued, for example, for ODSP and other income supports really need to be doubled, and it would probably still be tight. Now, because my interest is in mental health in particular, I'm a psych mental health nurse. What was happening at the same time was really a perfect storm in many ways. Uh, uh, in terms of this whole issue of deinstitutionalization, I'm really in favor of deinstitutionalization. For for hundreds of years, we did not have adequate treatments for mental illnesses. It was only in the 1950s that the first antipsychotics came to be. And a lot of the treatments around depression and bipolar disorder, we didn't even see until the 80s, well, 70s, 80s, where we saw that. Uh, so it is much better to not take people out of their homes, to be able to have people in the community. Um, we had so many planning documents in that period. Just take a look at where some of the numbers were, that we used to have 20,000 beds, went down to less than 5,000 psych beds. Uh, then, again, looking over the years, and we forget um, that these beds also provided food and accommodation while people were there. All these planning documents, those 37 planning documents in that period, all say that we had to increase community mental health services and look to make sure these other needs were being met. They were not. The other thing around deinstitutionalization, dehospitalization, our psych hospitals, provincial hospitals, were actually built in the 1860s. For example, the old London Psychiatric Hospital was built in that period. The Hamilton one, a couple of years later, that I worked in Hamilton. The reason, if you go back to the debates in Parliament at the time, why we needed this system is because people with mental illness were in poor houses, and it was considered not a humane way to treat mental illness. Gee, what is our modern equivalent of a poor house, right? So, and again, the funding has not kept up. And we did not have the adequate move. And this was not just Canada. This is mirrored around. It was like we had a good news story in terms of better treatment for mental health, but it didn't address the stigma issue, and it did not totally address it. And this one just, again, looks at the stigma issue. Heart disease, just another excuse for lazy people not to work. Imagine if we treated everyone the way we treat people with mental illnesses, including addiction. So what about that mute? Sorry, about that music that stopped. And I've talked about this point already. So I'm going to just go on and just say, do we have any quick questions around the model of musical chairs before we go on? Comments or questions?
And just again, if you could put your hand up, we can call on you specifically or put something in the chat.
Does it make sense?
Yeah, it's
Yeah, music prepares, everyone loses.
mhm.
Well, there's very few winners in the game of musical chairs up.
Mhm.
Yeah, and it makes sense. Like we are talking about complex systems interacting, but it is a way of understanding it. Is there any other comments I'm missing here? Okay, I'm going to move on. I will have more time at the end. So what can be done about it? And again, uh, it, we it's a bigger issue than at the community level. Um, put off artificial chair security. Yes, yes, yes. Profiting off artificial chair security. The other thing is, what that reminds me of too is even in the actual game of musical chair, does everyone have equal access to the chairs? Are some people more nimble than others? Do some people have more advantage than others in grabbing a chair? What about someone in a wheelchair? What about someone with chronic arthritis or whatever? Does everyone have that equal advantage? Some people are just lucky you have to be standing in front of a chair and it's almost luck. But even within the game, there are equity issues. So when I would do these participatory action projects related, and I've done many different groups on projects related to homelessness. I'm doing one right now with women veterans. We did the first study with veterans in Canada. The same time we were doing that, we're doing something with homeless youth. We've looked at uh, more general mental health populations, people with addiction, et cetera, families. Um, when we have people sit around the table with a lived experience, one of the things they say is the most important to acknowledge it as a system failure rather than a personal failure. If we understand the broader game, we can realize it's set up that some people will become homeless. And we need to look at it at that systems level rather than, oh, what did that person go wrong? Or as I was saying at the beginning, oh, it's about their housing skills. They don't have budgeting skills, right? We'll look at that amount of money. I always remember when you remember when the $2 co-payment for medication came into play? And I remember a client I was working with coming that was actually came in with all his budgets with me. They sat down and said, "Could you help me with this? I see if I'm missing anything. And as a nurse, I want you to tell me what the best solution is here. I'm already balancing my ODSP by just eating twice a day. It's the only way I can make my budget work is I cannot eat more than 2 times a day. Now with this $2 co-payment that the government said would not impact anyone because it's only $2 a month per medication per month. And sometimes people are on a lot of medications. I've looked at the amount of medication on what this is in. So as a nurse, what would be healthier for me to go to one meal a day or to just take my meds every other day? What would be the healthier solution? Well, what we were actually able to do is to get a pharmacist who was willing to waive the $2 so that the person could continue to take their meds and only twice a day. But we need to acknowledge that this is a systems failure. That does not mean you cannot act locally. You still need solutions, and but the solutions will not work if they do not cross sectors. So when we looked at, for example, things like preventing discharge to homelessness, we can't do that purely from the hospital perspective without including income support, without including the homeless sector, because all of them play a part in the game. And we also have to advocate strategies that increase the chairs or reduce the people circling. And again, for anything that is an anti-poverty strategy will reduce the people circling. And here's just some example of increasing the chairs. We know the city has put a big investment both in the municipal governments and as well as through getting subsidies provincially and federally, as well as private donations that has allowed an increase in public housing. And if, again, it has to be public or subsidized or some kind of supported, some support for that housing for the income levels we're talking about. The other thing is around the creative use of rent subsidies. We were in our homeless veteran project, and as you know, London was the first community in Canada to functionally end veteran homelessness. We used a lot of rent subsidies to allow for neighborhood of choice. When I worked with homeless youth, it was funny because we were doing that project at the same time. And one of the problems was around, most of them were on OW rather than ODSP. There's a reluctance, even when people have clear mental health problems, that people are reluctant to move too quickly to ODSP. We had both groups on our advisory group because, again, we need collaboration. And I remember Ontario Works telling us that it would not be clawed back if it was a gift from a religious organization. So we worked with the Sisters of St. Joseph. The youth, our average subsidy for the veterans was $250 a month. Once we got them set up with FACT, they could easily pick that up. The youth said, don't give us anything near that. We'll never be able to pick it up when we get employment. We want $50 to move out of the downtown core and be further from the drug trade and sex trade. If we can get that little bit further from the downtown core, and we think we could do it for $50. The Sisters of St. Joseph agreed to do that. That was only $600 a year. Almost all, and we had 186 youth in that particular study. Almost all of them were, once they were settled, were able to go on to employment and no longer needed that after 12 months. The few that went to 8 months was because they had kids and they had other stuff they had to do. So you have to look at the subpopulation is what I'm saying here. But this allows more chairs because it allows people to access market housing in addition to public housing. And then just a reminder of what's been happening in some of the major policies. I'm going to go fairly quickly around housing development. And it's not that many years. We only had that national strategy come back into place in 2019. And much of that ended up being sidelined by the pandemic. So the right thing, but a little bit slow off the mark. The other thing to remind people over and over again that it actually costs more to keep someone homeless than to house them. This is the classic work by Steve Pomeroy. It's a bit outdated, but the CMHC is looking at updating that. I believe that Steve is going to be involved again with that. I don't know if that's come out officially or it's just my optimistic thinking. But they are in the process of updating these numbers, but all these numbers have gone up, but the proportions are still there. It costs more. One of the recent, I was working with CIHI, Canadian Institute of Health Information, on a recent document they released in 2024, April, if anyone wants to look it up. And that was when I was on an earlier committee I was on provincially. I was really saying we have to get hospitals and other provincial groups such as CAS and jails. We need a way of knowing how often they are discharging to homelessness. We need some more accountability in the data. And because when we were doing some of that work, it's not easy in the current system. So hospitals are now required. It was initially an initiative in Ontario, but it's been adopted. When that request from Ontario went to CIHI, it was decided to put it across the country that hospitals must report homelessness. So that took a few years before there's enough data to analyze. But basically that report that we put out to 2024 showed it doesn't matter why you come into hospital. If you come in homeless, you're sicker. It's going to cost twice as much to get you recovering. It's going to take twice as long. So the hospital costs are not fully adequately identified here, but it's twice the cost and therefore twice the time in a hospital bed. So that is a huge societal thing. So the people circling, um, again, I've been talking about our projects to prevent discharge to homelessness. We've been highly successful with this. Um, and I do say I don't know if there's any of I'm grateful to the Department of Psychiatry letting me annually talk. I'm going to be doing this, I think, in another week or so, to the psychiatry residents. I also talk to the psychology residents about not discharging to homelessness and to give them the evidence why it's a really bad idea. The reason I do that with the residents is what I would find. I had the psychiatrists on board, but then it was the off shift when we were most often seeing it, when they'd get that call saying, we got so many people in the ER, you got to discharge people right away. And it was interesting. A few years ago, we had a consultant come in from outside town and I'm just thinking at the time, okay, and say that they found in London there was a strange reluctance to discharge into homelessness, as if this was a problem. I actually took it as a sign of success. And we do have, for those out of town, we have implementation guides that we've developed on how to implement that strategy. If you're interested, we've done that with youth version, and most recently we've done it with psych wards, medical wards, and we have implementation guides. We also see these various approaches from these different projects. We also find social enterprises in some of our work are really good, a positive way of getting people back into employment, and sometimes into employment for the first time. So those are all strategies that help that. We talk about addressing vulnerability points. I'm going to pick up the pace here. And then I'm not going to go into detail on the homelessness work, other than I will say when we originally did work in this area, the literature was saying that it was a myth. People are not discharged into homelessness, which partially just says how long ago we are looking at that. But anyway, that that is also solution based. So we need to increase affordable housing, increase um, income supports, recognize that it's systemic, connect the policies together. Because the problem is the disconnect between these things, like the fact that deinstitutionalization happened at the same time income supports were cut by 25%, and that public housing was no longer being funded. If we don't connect the policies, we can create these kinds of problems. Recognize that homelessness is not a homogenous group. You need to have solutions for different subpopulations. A few examples. The types of supports people need, the amount of supports varies a lot. And then I talked about the relationship between health and housing. We don't have time to talk about individual. It affects individuals, even though it's a systemic issue. These are just a few of the ways that I see, but I want to give time for questions. So we'll talk, so that importance on advocacy needs to focus on solutions to, again, the same points I've raised, and I will go to questions, and then that's just a ruthless thing. Just in terms of the book that we've done on poverty, mental health, and social inclusion, it has a whole chapter that goes into that analogy in more detail. And then we also have a chapter in there, and you can just get the chapter. The library has copies, you don't have to buy it. But also a chapter looking at the way that this intersection, the way that things don't connect policy wise, and how that actually creates problems. So, questions from the audience?
Well, everyone is thinking, Cheryl. I just wanted to say thank you for this great presentation, and I'm really looking forward to the discussion. Yeah. So if you have questions, if you please put your hand up, and we'll kind of call on you individually, or if you wanted to kind of post your question in the chat,
Yep,
then
questions, comments, observations.